about the characteristics of atrial flutter and how to identify it on an EKG. We're also going to talk about some of the complications, nursing interventions, and treatments for A-flutter. So if you remember, the normal electrical conduction starts with the SA node. It sends an impulse down to the left and the right atria, and it causes the atria to contract. Then it goes down to the AV node, the bundle of His, the right and left bundle branches, Purkinje fibers, until the ventricles contract. When I have a patient in atrial flutter, they have irritable cells in the atria that produce an abnormal electrical impulse. And so this causes the atria to contract at a rapid rate of 250 to 300 beats per minute. Now, the AV node prevents most of these impulses from getting down to the ventricles. If it didn't do that, then the ventricles would also contract at the same rate that the atria are. Now, sometimes some of these impulses do get down to the ventricles. So the ventricles contract at a rate greater than 100 beats per minute. And we call this a flutter with rapid ventricular response. So because the atria are contracting so fast, it limits the amount of blood that goes in the atria. So therefore, less blood goes into the ventricles. So guess what? Our cardiac output is decreased. Now let's look at the next strip and identify the characteristics of a flutter and break it down on an EKG. So let's use the 6-step method to identify this rhythm. Number one, we got to look at the rhythm. Is it regular or irregular? So let's count the boxes in between the R waves. From here to here, we have 34. From here to here, we have 38. From here to here, we have 34. So actually, our rhythm is regular and irregular. That's the thing with a flutter. People can have either regular or irregular or both, and it's just normal for a flutter. Number two, let's look at the heart rate. Because we have more P waves than QRS, we got to count both. So let's do the P waves first. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26. And because I have a 6-second strip, I'm going to multiply by 10, and I have 260. Now let's count our R waves. 1, 2, 3, 4. So 4 times 10 is 40. So my atrial rate is 260 beats per minute, and my ventricular rate is 40 beats per minute. Now let's do step 3 and do the P to QRS ratio. Do I have one P wave for every QRS? And I definitely do not. I have way more P waves than I do QRS. If you look at this one, this would be 1, 2, 3, 4, 5, 6, 7. That would be a 7 to 1. Here it's 1, 2, 3, 4, 5, 6, and that would be a 6 to 1. So again, the P to QRS ratio will vary, and it is definitely not 1 to 1. In step 4, let's do the PR interval. And that actually is not measurable because we have way more P waves than we do QRS. Step 5, let's do the QRS complex. So we're just going to do this one right here. From here to here, we have 2 boxes, so 0.08 seconds, which is actually within the normal range. And in step 6, we're going to identify the rhythm, and our rhythm would be atrial flutter. Let's look at the next slide because I want to show you more characteristics regarding a flutter. So if you look at this strip, it's the same patient and the same rhythm being monitored on 2 different leads. Look at the P waves over here. They have what we call a sawtooth appearance to them. Whenever you see a sawtooth appearance on an EKG, always associate that with atrial flutter. Now, if you look at the top lead, it doesn't necessarily look like a sawtooth. It looks more wavy, so it could almost be confused. You can almost confuse it with AFib. So always get a 12-lead EKG when you're not sure what the rhythm is. That way you can confirm it. So let's recap the characteristics of a flutter. The rhythm is going to be regular or irregular. The heart rate, the atrial heart rate is going to be anywhere from 250 to 300 beats per minute, and the P waves have a sawtooth appearance. The ventricular heart rate is either going to be normal, high, or low. It just depends on the patient. The P to QRS ratio is definitely not going to be 1-to-1, and it varies. The PR interval is not measurable, and the QRS complex is going to be normal. Now let's talk about what to do with patients that have A flutter. So most patients that come in with A flutter, their signs and symptoms are usually palpitations, chest pain, or lightheadedness. The nursing interventions that we must carry out will be, number one, determine if it's chronic or acute. If they have chronic A flutter, we have got to just continue to monitor them as long as their heart rate is controlled and they are not in RVR. We got to make sure that they're taking some type of anticoagulant. Here's what happens with A flutter. The atria are contracting at such a fast pace that they don't have enough time to fill up with blood, or when they contract, they don't get rid of all the blood that's sitting in the atria. So the blood pools here. So this blood that's pooling in the atria clots up because it's not moving anywhere. Whenever those clots break loose, it goes straight to the brain and it causes a stroke. So our job as nurses is to monitor for any signs and symptoms of stroke and make sure that our patients are taking anticoagulants. Now, people who are in A flutter are at high risk for strokes, not as bad as AFib, because in A flutter, the atria still contracts, so it just decreases it, but they're still at risk for it. So therapeutic management for atrial flutter is to assess the patient, find out if it's chronic or acute. If it's acute and they are symptomatic, we got to try to convert them to sinus rhythm as soon as possible. Now, if it is chronic or acute, for the most part, they take the same medications, which would be antiarrhythmics, beta blockers, calcium channel blockers, and anticoagulants. If they are acute and they are symptomatic, usually we can start them on an amiodarone drip or a cardizem drip to try to control their rate. If that doesn't work, they will have a synchronized cardioversion, and that is where the defibrillator syncs with the R waves, so it delivers the shock after repolarization to prevent VFib. And if that doesn't work, patients will have an ablation. And that is where they come into the EP lab. My patient's got some big legs. And a catheter is inserted through the femoral veins, and it goes up to the heart. So what we try to do is find out determine what area in the atria is causing the extra electrical impulse, and then we burn it. So this creates a scar tissue, and then only the SA node will initiate that impulse, and the patient will be in normal sinus rhythm. Unfortunately, other areas of the atria may decide to act up, and then A flutter will return. But people can live with A flutter as long as the rate is controlled and they take their medications. It really doesn't cause that many complications. So the key points and your biggest takeaways to remember from this lesson are the abnormalities of atrial flutter. There are more P waves than there are QRS. The rhythm can be regular or irregular. There is a sawtooth appearance to the P waves. Always assess your patients and determine if it's chronic or acute. Monitor for signs and symptoms of stroke, and we got to prevent strokes from happening. The treatment for atrial flutter are medications, cardioversion, and ablations. So I hope that you guys have enjoyed this lesson and understand the characteristics of atrial flutter and nursing interventions and management. Make sure that you check out all of the resources that are attached to this lesson and keep practicing EKGs so that you can become more familiar with them. Now go out and be your best selves today, and as always, happy nursing.